Good afternoon, everyone. Thank you very much for coming along to Paisley and District's virtual U3A meeting. Lovely to see so many of you here today. This is our first virtual meeting and our first meeting of the new season. Please bear with us while we get to grips with the technology. We are, or some of us, myself included, are definitely newbies at this. You might find that it will take a little bit of time for presentations to upload, etc. So be a wee bit patient with us. We're doing our best and we're learning all the time. And that's what it's supposed to be about, isn't it? I'm sure many of you have experienced lots of different emotions over the last 6 months. I know I have. It's been a bit of an emotional roller coaster. We're living in very different times with restrictions on who we can see, where we can go, and we get confused about what the rules are. That's why I'm so delighted today that our speaker, Dr. Tom Brown, who's a retired consultant psychiatrist, has agreed to talk to us about our emotional well-being in a COVID-19 world. But before I move on to our guest speaker today, there are a few announcements. There's some Zoom housekeeping that I need to speak to you about. We are recording today's presentation. But fear not, the spotlight will be on our guest speaker and Douglas, my better half, who is going to be taking your questions. We're keen that you ask questions, and as Jane has kindly pointed out, as people have been entering the room, if you look to the bottom toolbar, there is the chat bubble. And if you press on that and go right along to the far right side, you can write your question. Please write it to everyone, and we will collate the questions, and Douglas will put these questions to Dr. Brown at the end of his presentation. There is all, and as Jane said as well, you can also write a little personal message to anyone you see, and that might be nice for people to do. You can also type in general questions if you have a question for myself, and I'll deal with them at the end. There is a reaction button again on the toolbar, and you can give a thumbs up or a clap, and it would be nice if we did that after Dr. Brown's speech today. Right, our programme today is today's guest speaker, questions by Douglas, and a thank you to Tom. We then move into breakout rooms, and we are only going to be in them for about 5 minutes today. This is a bit of a trial run. We've never done this before, so we'll see how it goes. When you're in your breakout rooms, you will not be muted, or you can unmute yourself and have a bit of a chat with people. This will be done randomly. The computer does that for us. And then we hope that you'll come back and join us for farewells at the end. A few final announcements to be made. I hope you all got Carol's email about the fees, and the good news is we're reducing the fees for this year. That is to take account of the fact that we're not paying for the Salvation Army Hall. I hope that pleases you, and I hope that encourages you to stay with the Paisley and District U3A. We're also delighted to say that we're going to put on a digital photography competition this year. Last year's was fantastic, and it's great that we're going to be joined by Robert Tabor, who was a guest judge last year, and Kate Cummings. So we're delighted about that. And we also have a new judge this year, Guy Hinks, who is a renowned photographer. And my final announcement that I want to make today before I hand you over to Dr. Brown is, I think we need to say a huge thank you to the group leaders who have been keeping in touch with everyone throughout the last 6 months. They have been doing virtual tours for people, they've been sending emails, they have been doing Zoom meetings, And I think that's actually tremendous, the work that they've done and the commitment and the time that people have put in. We are so very, very lucky with the group leaders that we have. So huge thanks to them from me, and I'm sure yourselves as well. So without further ado, I will pass you over to Dr. Tom Brown, our retired consultant psychiatrist. Thank you, Dr. Brown.
Thank you, Kathy. Hang on a minute, I'm trying to share my screen. I don't.
Yeah, did you press the green button at the bottom of the screen, Tom?
I did. It also
I
says.
had a problem with this earlier on as well. It didn't come up with my desktop. I would suggest.
It also says I'm screen sharing, but I'm not. Hang on a second.
Yeah, yes. That's it. That's it.
You see it now. Good.
Yeah.
Good. Hello, everybody, and thank you very much. Thanks for that good introduction, Kathy, that kind introduction, and thanks to Alana for inviting me. Until about 5 or 6 weeks ago, I didn't know of your existence, and I've been on your webpage, and I'm really fascinated by all the things you do, and it's an unexpected pleasure for me to be here to talk to you today. But before I start my talk, I need to put in a couple of caveats. The first is, I'm not a COVID-19 expert. The second is, I'm a retired doctor. So you might want to know why you ought to listen to a word I say. And here are some of the justifications for that. When I worked as what's called a liaison psychiatrist. Now, I suspect most of you will not know what a liaison psychiatrist is. A liaison psychiatrist is a psychiatrist who works at the interface between physical medicine and psychological medicine. And liaison psychiatrists don't work in psychiatric services. They work in general medical services, in general hospitals. And I was based in the Western Infirmary in Glasgow, which was knocked down months after I retired, as the Queen Elizabeth Hospital was developing, and it will never be the Southern General to me, but it's the Queen Elizabeth Hospital. So I was based in the Western General, and the patients I saw were in the Western Infirmary, in Gartnavel General, or in the Golden Jubilee Hospital. These were the three hospitals that we covered, and they usually had some other kind of physical illness. And so I dealt with psychiatry as it appeared in the general hospital. So we saw overdoses, for example. We saw psychiatric emergencies turning up at A&E, and we saw the physically ill people in the hospital who had comorbid psychiatric illness. And relevant to this talk, part of my patch, as it were, was the Brownlee Centre, which was at Gartnavel General Hospital, and which some of you might know is the Regional Infectious Diseases Centre for the west of Scotland. So I have got experience of seeing people with infectious diseases, including serious infectious diseases. As I said to some of my still working psychiatrists at the start of this whole business, I'm one of the few psychiatrists who actually has experience of interviewing folk wearing PPE. Because sometimes in the Brownlee, if people were very infectious, contagious, we had to interview them wearing gloves, gowns, hats, masks, the full works. So I do actually have some experience of interviewing patients in that setting, and I've got a lot of experience of interviewing patients in an intensive care unit setting because I worked in general hospitals. So these are some of the reasons why I've got some relevant experience to this. What I'm going to do today is, firstly, I'm going to say a wee bit about the relationship between physical and mental illness, because it is considerable. Secondly, I'm going to tell you a bit about what we know about the psychological consequences of COVID-19. Now, given when this started, this is pretty early days in terms of research, both into physical and psychological aspects of it. So this is very preliminary. However, we can infer and predict quite a lot from things that have been like this in the past, previous big epidemics, things like SARS, for example. So we can make some predictions, though I'm going to suggest there are aspects of the current situation that, if they're not unique, they're pretty rare and exceptional. And in the second half of my talk, I'm going to be a bit more practical, and I'm going to say a bit about how you can look after yourselves and others during this time. The first and important preliminary point to make is that there is a huge link between physical illness and psychiatric illness. Most serious physical illnesses increase the risk for people who have them of having a psychiatric illness at some time in the course of their illness. So, for example, the rate of depression in people who've had heart attacks is between 20 and 40%, considerably more than double the rate in the population. For Parkinson's disease, it's about 40%. Similarly for stroke. It's also high for things like diabetes and HIV/AIDS. So any acute severe illness like heart attacks or chronic illness is going to be associated with higher rates of psychiatric illness. And that is a very robust finding. That is not my opinion, that's pretty much fact. There's some argument about the numbers, but even at the low end of the estimates are you just about double your chances. If you've got an illness that affects your central nervous system, and you'll see that from things like Parkinson's disease, stroke, that's even higher. And I can give you some recent information later in the talk, but COVID-19 definitely does affect people's central nervous system in some cases, and can do so quite severely. If you have a medical illness, and just think about this in relation to COVID or what you know about COVID. If you have a medical illness, there are things that increase your chances of becoming psychiatrically unwell as well. So if it's very painful, particularly if that's chronic, that increases your chances. That's not particularly the case with COVID, though some of the long-term sequelae of COVID may include muscle pain and fatigue. If the illness is life-threatening, which for a proportion of folk with COVID it most certainly is, that increases your risk for a psychiatric illness. If it becomes chronic, it goes on and on, that increases your risk. And we know early doors, and this is the case with lots of viral infections, that there are, for some people, a minority, but for a significant number of people, there are chronic problems following infection with COVID. If treatment is unpleasant and demanding, that increases your chance. Let me give you an example. When I worked at the Western and Gat Naval General, I was probably in the renal dialysis unit every day. There's a good example of a demanding treatment. Not particularly unpleasant in the painful sense, but it's very demanding. You're going in there for half a day, 3 times a week, plus travel time. Very, very, very high rates of depression in these people. If you're isolated and you don't have social support, that increases your risk. If you have a history of psychiatric illness before you become physically ill, that increases your risk. If you misuse alcohol or drugs, that increases your risk. And also sometimes the drugs that are prescribed to treat your physical illness might increase the risk of psychiatric illness by causing depressive or anxiety symptoms. I'm giving you some examples there. Steroids, which are used in COVID-19, and some chemotherapy regimes can do that. So the illness itself increases your risk, and there are a number of aspects of the illness that I've listed here that can increase your risk for becoming psychiatrically unwell. Although I'm retired, I still read medical journals. I still subscribe to the British Medical Journal. And since this outbreak started, there have been articles every single week in the British Medical Journal, some of them just providing information. At this stage, not a lot of them are very solid research, but 1 or 2 of them are. So I've read them. I've also drawn heavily on 2 big review articles, one from a Canadian author called journal called Science Forum, and another, the first author of this paper is a guy called Dubey, and it's published in Diabetes and Metabolic Syndromes. You might think that's a strange place to find an article about COVID. I'm guessing they were interested in publishing it because diabetes is a major risk factor for dying of COVID if you get it. There have also been 5 articles in the British Journal of Psychiatry in the last 3 months about COVID that I'll say a bit about. And also, right at the start of this outbreak, an ex-colleague of mine, Tayyab Tahir, who's a professor of psychiatry in Cardiff, actually contacted me about some research he was doing to ask me some questions and garner my opinion about it. And I've talked to him as recently as last Saturday, so I'm aware of the kind of work he's been doing. So from these papers, and some of this is self-evident, these are some of the societal consequences of COVID-19 that may impact on people's mental health. And I'd say one of the biggest ones in this that distinguishes it from other outbreaks of infectious diseases have been the emphasis on a need for self-isolation and quarantine. And doubtless there'll be people asking questions about that. Along with that, social distancing, which is very active for us just now, particularly people living in the west of Scotland, closure of businesses and all the consequences of that, closure of schools for several months, an increased focus on hygiene practices, and a huge impact on normal activities. And I've listed some weddings and funerals, particularly striking, particularly funerals. I mean, how normally having a funeral is an important part of the ritual of bereavement. And that's been severely disrupted during this. And you would predict would increase the risk of difficult grief reactions, given not only the circumstances of the funeral, but people being unable to visit or be with their loved ones when they've been dying. And of course, all these things, and I'm sure you can add to the list, but these are the things that the journal articles highlight as most important, pose a huge threat because they cause fear, they cause financial uncertainty, financial hardship, stress. All these things increase the risk of mental health problems. Let me say a bit about quarantine and social isolation, because both these review articles that I mentioned highlight that the early indicators that this is a huge issue psychologically, and some of the consequences of quarantine I've listed there: anxiety, panic attacks, which are different, they're discrete, paranoid symptoms about other people, about the government, about various, things. So paranoid symptoms definitely increase, and that can be reflected in what people are saying and sharing via social media. Depression, compulsive symptoms, checking, probably to do with the increased focus on social distancing, on hygiene practices, definitely a risk. And hoarding, we saw hoarding behaviours emerging right from week one. In fact, even when it was just a threat, toilet roll and pasta and tins of tomatoes disappearing from the shelves of supermarkets. And we're told that's been happening again in the last week as cases rise. And the supermarkets are once again imposing, some of them are anyway, imposing limits on how much of certain items you can buy, because people are hoarding. And there's an element of panic to that, there's an element of understandability to it, but people are hoarding. And a psychologist who'd actually written about pandemics before this one happened, predicting what was going to happen, wrote in a journal early on in this that the one thing he could not have predicted is that folk would hoard toilet roll. Some of the other stuff was a bit more predictable, but why toilet roll? Post-traumatic stress disorder. Now, I'm just going to caution you here. Post-traumatic stress disorder has got quite a specific psychiatric meaning. Nearly everybody who tells me they've got post-traumatic stress disorder or they know somebody who's got it have not got it. They may have psychiatric problems, but they've not got PTSD. The flip side of that is that when I was working and also in my medical legal practice, most people I saw who did have PTSD, it often hadn't been recognised, and it certainly hadn't been given good treatment. But you would expect, there are aspects of this that you would expect lead to post-traumatic stress disorder, not least people's experiences in coronary care units, okay? Not coronary care units, intensive care units. Because we used to even, when I was working, it was not that uncommon for folk after stretches in ICU to develop PTSD symptoms for a variety of reasons. They're pretty difficult places to be. And you obviously, by definition, exceptionally ill when you're there. and substance misuse as well. And even, anecdotally, as well as from the stuff in the journals, a lot of folk admit to drinking more during this. You're locked in, you're anxious. There are less reasons for you not to drink. You may not be going to work the next day. You may not be driving. So it can creep up and creep up. And there are some early published studies, particularly from China, showing an increase in all of these things. The next thing I want to highlight is that when you talk about the spread of disease, not just COVID-19, that psychological factors are hugely important in the spread of disease. They're also important. They've also got an important role in social disorder. If you think of things like fear, anxiety, being paranoid, and all that, sometimes fueled by substance misuse, which makes it all worse. So psychological factors have got an important role in social disorder, but also in the spread of the disease itself. Somebody's probably already asked a question about this. I don't know, but it's such a big thing, the role of the media in this. And it's a two-edged sword, isn't it? Because although the media are clearly important in disseminating information, that can be for good and for ill, probably a bit of both. And every medical journal and most articles that I've read have been critical of the media, especially for exaggerating risks by using emotionally charged images and language. And they have been particularly critical of social media. The medical press has been particularly critical of social media. And of course, the media can increase fear, can increase anxiety, and also they can lead to something that psychologists called learned helplessness. You listen to the broadcasts, you read the news, and you think, to use Sergeant Fraser and Dad's Army's phrase, we're doomed. There's nothing we can do about it. So we'll just throw the towel in. That's learned helplessness. The other thing I've noticed, because I use social media a bit, I use Facebook, is it can definitely enhance divisiveness. I've seen some very ill-mannered and ill-tempered diatribes in social media, and people being accused of this, that, and the other. So, it's certainly not been my experience that a lot of it fosters goodwill and harmony, though some of it does, and I'll come back to that. The phrase social media infodemic has been used by a few people, including the boss of the World Health Organization, to whom we'll come back to in a second. And if one thinks of some of the things that are a consequence of that, and I made this slide probably nearly 3 weeks ago, so before the universities had gone back and what we've heard about them, but already there were signs of stigmatization of young people for breaking the curfews, for example, not wearing masks, gathering in large crowds, stuff like that. Racism, part of it, for example, Donald Trump calling it the Chinese disease or the Chinese virus, a partial truth, but not a helpful way to put it. Xenophobia, and it's definitely been quite divisive. And social media are also a good place for circulating conspiracy theories and a good place for vax deniers to air their grievances. And I will doubt, again, in questions, I will doubt this come back to these things. This is a quote from the World Health Organization chair. The coronavirus, he refers to the coronavirus infodemic, which is breeding fright and panic by laying out uncharted, mind-boggling rumours, flamboyant news propaganda, and sensationalism. So whatever your view in the media, it's definitely a big player in this and has a big role to play in how we respond to it, as do government. And I'm trying to be non-political here, and I will try to be non-political because there are almost certainly a range of political views in the room. Government's clearly got a role in providing information. My experience, both at a UK level and the Scotland level, is that the information they provide on their websites on the whole is pretty good. And they do better on their websites often than they do in broadcast media. I'm not asking you to discuss that just now. I just put the word discuss in because I know people will have their own views on that. The government also has a role in the provision of services and support to the NHS and care homes, and they've been heavily criticised for that, particularly early on in this, and also in providing economic support to the many sectors of the community who are suffering because of this. And how the government responds is key. And again, as we've been seeing and hearing in the media, different governments have responded in different ways. And we have our own opinions of which is good and which is bad. And in fact, the evidence in that's conflicting. To give you one example, there are countries who've had very strict shutdowns who've done exceptionally well. And there are countries who've had much more lax regimes, for example, Sweden, who appear to have been doing better. There's a caveat there. Cases have been increasing again in Sweden in the last week. And my view on that, for what it's worth, is it's much too early to say too much about that. So going back to how psychological factors affect people's response, they may affect your acceptance and adherence to various hygiene practices, to your attitude to social distancing, and also to whether or not you'll accept a vaccine when one becomes available, because one will become available, though it may be pretty far down the line, a lot further down the line than many folk are hoping or predicting. But as with flu, it almost certainly will become available. But whether folk will accept it remains to be seen. What are the important psychological factors? There are loads, but I've highlighted 3 because these are the ones that jump out from the published papers and journals so far. The first one is unrealistic optimism bias, underestimating danger, and this leads to, just at the moment, not taking precautions, being blasé about these. Later on, it will be one factor, but by no means the only one, leading to refusal of vaccines. And generally speaking, people who've got a strong and realistic optimism bias are seen as more likely to pose a societal threat. I mean, if you just leave COVID out of it, reduction in uptake of vaccines is already seen as a societal threat and a bad thing. And I'm going to try to be even-handed about lots of things, but I nail my colours to the mast. There are just about no doctors that think vaccination's a bad thing. That's not about COVID vaccine, and the medical press is pretty hard on vax deniers. The second thing that's a big factor here is health anxiety. Now, health anxiety exists on a spectrum. Some of us are stoics. I'm fairly stoical, for example, whereas others in my family are fairly neurotic. They worry about anytime they have minor symptoms. So, and high health anxiety leads to overestimating danger. That's the key aspect of it. They overestimate danger. They increase the risk. They have a perceived increased risk of bad things happening, and they also have an increased risk on what's going to happen if bad things happen to them. So they overestimate danger on several fronts. They tend to pose an increased demand on services with excessive consulting. They love the self-isolation bit, but that puts them at risk of depression. And they also engage in compulsive symptoms, checking, etc. The third psychological factor that is relevant and may become increasingly relevant with the passage of time is intolerance of uncertainty. A high need for things to be predictable, and for the foreseeable future, I'm pretty sure things will not be predictable. And there we go, other challenges. The first one is uncertainty about the future, and that's there, and it's going to remain there. Will the need for lifestyle changes be prolonged? Will there be a new normal, as it were? Will we start wearing masks? I mean, some societies have been doing this for ages. Some of you, like me, I mean, part of I'd worked for the Royal College of Psychiatrists latterly, as well as the NHS. So I was in London about 3 times a month, this about 10 years ago, for a few years. And any time I walked around any of London's airport, there were people, mostly Oriental, wearing masks. Will that become the new normal for us? Will COVID go away? Or will it be a bit like seasonal flu? For what it's worth, the majority medical opinion just now is that it will probably not go away. It will probably be a bit like seasonal flu. The virus will be there, but it will change from year to year. And as with seasonal flu, even if we get a vaccine for it, it will have to change as well as the virus changes. So this might be something that individually and as a society we have to live with for a long while. There are a huge number of vulnerable groups. Now, in terms of becoming very ill with COVID-19, children and adolescents are not a high-risk group. I mean, you'll have all read in papers that and it is a tiny number of children have become seriously ill, but they're not at high risk from the actual illness. What they're at very high risk for are the kind of things that have been happening around the illness at a crucial time in their education and their emotional and social development. They are being, they're having to engage in behaviours that are very difficult. They're isolated, or they were isolated for quite a long period of time. They are, they're having to make major behavioural changes. And as a youth worker with the churches in our community pointed out to me at the weekend when I was talking to her about it, one of the things that children and adolescents are having to juggle with is different behaviours in different settings. So when they're in school, they're not really socially isolated, certainly the secondary schools as far as I can see. They mix, they do pretty much what they're normally doing. Then the minute they come out of school, they're supposed to be 2 meters apart, wearing masks in shops, blah, blah, blah. So they're juggling behaviours perhaps more than the rest of us. The old people are clearly vulnerable medically and probably for a number of social reasons, as are the homeless, as are people who are poor and unemployed, as are immigrants, and I'll come back to that. Well, I'll come back to it now, because one of the articles in the British Journal of Psychiatry was entitled, "Is the Coronavirus Racist?" And it most definitely is. Black and minority ethnic groups are at increased risk for a variety of reasons, some of which are biological, some of which are psychological. And at the weekend, I chaired a scientific meeting via Zoom of the British Pakistani Psychiatrists Association. The reason I was chairing it was that two of them used to work for me in Glasgow and they invited me to chair it. And obviously this was quite a pressing question for them. Is the coronavirus racist? And several of them alluded to it in their presentations. And it most certainly is in the sense I've just said. Frontline health and social care workers are clearly vulnerable groups, and we got used to applauding them once a week. And we'll come on to excess deaths probably in the question, but there's absolutely no doubt that there has been a significant number of excess deaths in frontline health and social care workers due to COVID-19. There's no doubt about that. We can debate about the increase in society if somebody wants to later on, the excess deaths in society, but there has been an excess death in frontline health and social care workers. I sometimes feel a bit sorry that because health services and social care workers are very much, there in the front line, there are lots of other essential workers who must be at risk, providing services. You can probably name loads of them: funeral directors, people working in some shops and some other kinds of businesses, refuse collectors. There are loads of essential workers and who are arguably also in vulnerable groups. And most definitely in a vulnerable group are people with a previous history of psychiatric illness. Right, that's all I'm going to tell you about from the published papers. I'm now going on to practical stuff. What can you do to help yourself and others? I could have given you a list of stuff here, but I've confined it to just two, because the first one in particular has got links to lots of other websites. There's really, really good information on the Mental Health Foundation's website and I've put the email address on the website address there. And I'm quite happy for my slides to be made available to you. And there's a lot of good common sense general advice on it with links to other helpful resources. And indeed, a lot of what I'm going to say you'll find on the Mental Health Foundation website. If someone actually is psychiatrically unwell and has depression or anxiety, there's a really, really good website called Living Life to the Full, www.llttf.com, which is self-help for depression and anxiety using cognitive behavioral therapy. That website was designed and developed by one of my former colleagues in Glasgow, Professor Chris Williams. And it's free, though you do have to register to use it, but it's free. Excuse me. Right, what can you do to help? The first thing is plan your day, have some structure to your day. But the more locked in you are, the more important that is. And as you know, I was a liaison psychiatrist. I was also trained as a cognitive therapist. And when I did CBT with people, one of the things, this was something I used to urge them to do, was particularly folk who were doing very, very little, was put some structure into your day, schedule each day to do at least 2 things that you get enjoyment out of, and to which they would usually reply to me, I don't get enjoyment out of anything because they're depressed. To which my reply would be, schedule 2 things that you used to get enjoyment out of. Sometimes because if they're not very severely depressed, when they do these things, they counter to their negative predictions, they get some pleasure out of them. Also, I say to people, schedule to do a couple of things every day that you need to do, like essential bits of business or housework or something. So have some structure in your day. And it's that, if you don't find that easy to do, it sometimes helps to write it down. And if you're living with somebody else, to share it with them. Exercise, even indoors. I had one stroke of good fortune. I didn't tell you this because you didn't need to know, but I've got multiple sclerosis. I can still get about, but I'm very, very slow. And I can't walk miles, for example. I used to cycle a lot, and I can't now because my balance is so poor. So about a year ago to the week almost, I bought an exercise bike, quite a flash one. So I can now cycle anywhere on the planet as long as Google Maps go there. So I've been exercising on my bike every day. So even if you have to exercise indoors, try and do some exercise. If you need it, try and learn to use some kind of relaxation technique. And the one that's most commonly used is something called progressive muscular relaxation. And I've given you a website reference to that, which is quite helpful. It's something you need to practice, but you can learn to do it quite easy. Stay connected, and I don't mean just browse the internet all day. That's not a good idea. But as we are doing so just now, these connections might be through Zoom, so you can still talk to your friends and family and be creative about that. So for example, I've got 3 grown-up children who don't live at home. We started doing family quizzes over Zoom. So there are various things you can do to try and stay in touch with people. The second thing I would encourage you to do is to reflect a bit in a positive way. So reflect on what went well today, rather than what went badly. And if need be, keep a journal of that. I'm called it a gratitude journal. Some folk call it a positive log. One of my friends has set herself a challenge during this to post on Facebook every day something that she is thankful for, which is, it's a good challenge. It's quite a good thing to do. And they're usually fairly prosaic things, but often things we take for granted. So for example, today she's posted that she can still get most of the foods that she likes. So post a gratitude, don't necessarily post it, but keep some kind of gratitude journal. Some of you have probably heard of something called mindfulness. It's a bit more than just relaxation. But again, there's loads of information about mindfulness, which is a kind of meditation that you can practice, which some people find helpful. And be kind to yourself rather than overly self-critical. What else can you do to help? Sleep and exercise, good sleep hygiene. I can say a bit more about that if people want me to at the end, but make sure you get enough sleep. Continue to talk to people. Eat well, don't drink too much, don't misuse drugs. And you know, it's unlikely that most of you are snorting cocaine, you know, or shooting heroin, but I've had one very graphic experience during this of an old lady I know abusing her prescribed drugs because they relieve her anxiety. Don't do that. It can be quite dangerous. So, and quite a lot of you are probably on prescribed drugs. And this is an important one because there's been quite a lot, and rightly so, in the press about what's not happening with medical services during this. Don't put off consulting because you think you're going to trouble the doctor or the nurse. If it's something you would normally consult about it. So don't ignore things that you would normally consult with. I would suggest that you ration your use of the media and don't become compulsive, for example, in checking every day how many people have died of it. And so ration your use of the media and social media because it's so unreliable, social media, as a source of information about anything. It can be quite entertaining and it's a good way to keep in touch with friends. You know, I've kept in touch with a few friends in New Zealand, for example, via social media, but ration your media contact and schedule enjoyable activities, as I said earlier. If you're feeling anxious, there's the Living Life to the Full website I told you about. Here's some very basic stuff, some of which I've already said. Control what can be controlled. Just think about the things that are contributing to your anxiety, and some of them may be stuff that you may not be able to do much about. So try and deal with the things that you can do something about. Pace yourself. As I said, use something like relaxation or mindfulness and keep a positive log. Talk to people who make demands on you. For example, employers. Now, I don't know how many of you are still in employment, but technically I'm an employer, for example, because I'm chair of a charity, the board of trustees of a charity, and we've got a small number of employees. And one of them contacted me the other day to talk about the stress that she was experiencing in relation to her work. And that's exactly the right thing to do. Don't let things simmer, and don't speculate on what people might say or do. Actually talk to them. Focus on the here and now, rather than trying to predict the unpredictable about what might be happening next April, for example. And bring that which you know and that which is certain into focus. Talk to people you trust, talk to your friends. I think I'm going to leave it there. I think I'll probably talk for about 30-35 minutes. And Douglas, I'm happy to take questions, of which I'm sure you have some. And I'll stop sharing my screen. There we go.
Record.
Record off, yeah. Hold on. Just doing a little housekeeping.